welcome, Dr. Heidi Flagg. I more or less introduced you. I will quickly read your bio. I did let everyone know who's joining us so far that we are talking about the psychological impact of perimenopause.
Yep.
Dr. Heidi Snyder Flagg is a founder and managing partner of Spring OBGYN, a private practice in New York City since 2002. Since completing her OB/GYN residency at Brown's Women and Infants Hospital in 1999, Dr. Flagg's clinical interests have spanned the spectrum of the woman's reproductive cycle with a current focus on perimenopausal and menopausal issues, challenges, and treatments. She is a certified menopausal specialist. She is a part of the Every Mother Counts Founders Circle and holds positions on the H.L. Snyder Medical Foundation and the Experimental Science Now boards. Welcome again, Dr. Flagg. So a couple of things. One, this study came out, published in the Journal of Affective Disorders, that found that women are about 40% more likely to experience depression during perimenopause than after menopause. And you and I, Dr. Flagg, had an opportunity to kind of touch base ahead of this conversation. And you remarked to me that so many women walk into your practice struggling and suffering and expressing feelings of sadness, anxiety, depression, feeling sort of out of sorts, unmotivated, a whole host of sort of symptoms that they may not attribute to perimenopause. And I was thinking that they may not even have a conversation about it's almost happenstance that they're in your office maybe for a PAP or something else.
Yep.
And then, you're asking them how they're doing. But the thing that really struck me about this conversation you were sharing with me, or the many conversations, was that you were so moved by their stories. And I think so much so that you wanted to kind of amplify this in particular. So take me a little bit through that and why this matters so much to you.
It just matters tremendously because I think the impact is so profound, such a vital part of a woman's life in terms of at least our modern day life. We are hit with, we have young kids at home potentially, we have big jobs, aging parents, right? It's such an impactful time, but even so, but let me go back a little bit. I mean, I was lucky enough, I was trained in the 90s, so I actually had some menopausal training a little bit. I ended up doing a research study on and osteoporosis, bone health as a fourth-year medical student. And then I've written, this is ages me, of course, but I've written prescriptions for Prempro and Premarin.
Right.
So, but, so there was menopause focus, right? It was 60-year-olds, that sort of thing. There was zero training on perimenopause, right? It was, you went from having babies, fertility, dealing with that, and then menopause. And there's this 20-year gap or even, 15-year gap in there where women were really ignored that space tremendously. And this is what got my attention when even before I went off the OB call schedule, because I was hearing my 40-year-olds say these things and talk about exaggerated PMS and how they weren't sleeping and they would cry. I mean, I've wiped so many tears. The tissue's right behind me. I just reach back and grab it and hand it forward.
Mm-hmm.
So this is what got my attention, where I thought, my gosh, this is where the suffering is happening. It's in their 40s and early 50s and mid 50s where we're seeing tremendous suffering, all these symptoms. And, so my focus went there, and I was listening and asking more questions. I've learned everything for my patients. And then from there, of course, you go to your sources, right. The Menopause Society, or you start doing Google searches, you go to your usual places, and, sure enough, are there studies? There's some, but there's not enough. So this is what really got my attention, was all the women that I've talked to that talked about all these tremendous symptoms with major impact on their day-to-day.
Right. So, Dr. Flagg, when you're sitting there and you're listening to these stories and you're seeing the suffering and you're offering what in return?
Right.
That's so important.
Right. So let me just say this. Our current insurance-based medical system leaves zero space and time for the discussion. as you said, often they're coming in for their annual exam, their pap smear, where we as an OBGYN or some primary care physicians are ruling out and screening for all these cancers, right? It's a 15, 20-minute visit. It's insane, right? Like, so there's that problem. And, you know, even well-meaning doctors that to be able to create time and space and a level of comfort where a woman will tell you these very personal details is probably the biggest challenge. You have to be open to it. You have to ask the right questions. You have to be very inviting and be able to listen, right? But it's really difficult when you're trying to do a pelvic exam in the midst of all this. So,
Right.
so it's what did I do? What did I do? The discussion has changed tremendously. How did I approach it? Very carefully, quite frankly, up until about a couple years ago. You know, I've before that, I really had to read my audience. I literally have had talked to a 42-year-old. I have this example in my head because I remember it so well. She was telling me about her her mood changes. Her periods were getting a little closer together, a little heavier. She was exhausted. Maybe wasn't sleeping very well. I mean, you know, all the real, right? And she was there for her annual. And I said at one point, gosh, this is a number of years ago. Let me put it at like 2015.
Sure.
Gosh, this might be perimenopause. I said perimenopause. I said the word. And she reeled back and got really upset with me. She's like, I'm not in menopause. And I was like, you
Yeah.
are. You know, so we're going to talk about the, you know, the branding of that word and whether you put perimenopause, but the menopause, right? In our society, unfortunately, you say that word out loud, you're old, you're sidelined, you're, you know, put out to pasture, whatever all the terms are, right? So I said that. It was obviously the wrong thing to say at that moment. But so, you know, I kind of mind my audience. I try to understand their context, what the goals are. And, you know, if I feel like there's an opening there to say, gosh, you know, let's try some hormone therapy. But in their 40s, they still need birth control often if they're sexually active. And so that, you know, the conversation, we have to start talking goals and priorities, right? And I mean, quite frankly, you know, there are lots of different hormone therapy options. We're using more biosimilar products these days, but I've used a low dose of birth control pill during the 40s, which is actually very beneficial and
Dr.
effective.
Flagg, I just want to pause you for a second. I asked my question, I think, sort of out of order. First of all, I want to say thank you for sort of laying out how the conversation has
Yeah,
changed. You know, how it has changed since you have been in practice and you are a clinician and you're seeing women actually coming in and suffering and struggling and needing very specific you know, tests and conversations and offerings. That's one part of it. But then sort of out in the ether, right? It has really changed tremendously. And it's changed just in the last year, quite frankly, and what we're talking about and how open we are about all of it. And all of that is to the benefit of doctors and patients.
everyone. Yeah.
Absolutely. Families, the whole thing. I I wonder if you could sort of take us before we get into the solutions,
Yeah.
if you can take us through the hormone sort of we hear about estrogen all the time. If that's the major, then great, then hover on that longer. But sort of which hormones should we as patients be mindful of when we go into our doctor, when we are suspecting that we may be perimenopausal, and more of us might sort of be open to that and kind of willing to put our arms around that, but also being um, aware when we step into a doctor's office that our time is limited. Certainly platforms like ours at Alloy offers a whole other kind of window into getting solutions and having conversations in a different way. But just to kind of understand if we are feeling depressed, anxious, moody, unplugged, unmotivated, all of these things that we may be feeling for many of us for the first time, late 30s, early 40s, mid 40s, which hormones should we be thinking about?
Right. It's a great question. And it was difficult to answer your question, like, what do I offer? Because it is,
I'm glad I
well,
backed it up. We needed that.
yes. And I mean, maybe my response should have simply been, it's very individualized based on who's sitting in front of it, because it truly is. This is an individualized conversation and journey for every woman. It's going to be a little bit different. Maybe I should start by, perimenopause. I don't know. Should we do some basic definitions,
Sure.
right?
Have
Let's
at it.
basic
Please.
definitions. And our focus was going to be, the mood disorders. And you mentioned right at the beginning, depression. 40% of women get depressed. Even more, upwards of like 80% get depressive symptoms intermittently, right? They don't meet criteria for depression. But let's talk about perimenopause and menopause. They're different, right? There's premenopause, then there's perimenopause. Perimenopause is actually, as you mentioned, again, 4 to 12 year, sometimes 14-year process for women. It's broken up into 2 phases. There's the early phase and the late phase. The early phase is also called the loop phase, and I've affectionately called it hyperdrive. Interestingly enough, and some people call it the roller coaster, which that's absolutely what it is. You can be very high levels of hormone levels and then very low all in the same day. And that's where this incredible swing of moods and symptoms comes from. And by the way, it's coming from the brain, right? It's the brain trying to accommodate a low estrogen or a too high estrogen state. This
So
is
important to know.
very important to know. We focus on the ovaries as a center of this, and they are, but the brain and the ovaries talk to each other. And it's the brain and the ovary communication that is what's fully disrupted during this time period. And that is why so many women feel as badly as they do. Dr. Lisa Mosconi does incredible research on this front, and I'm just absolutely love her work.
Yeah.
So
yeah, we too.
I grabbed her paper. I'm getting away from the original question, but the 20 in her study on brain fog, I clutched it in my hands. I shoved it in my pocket of my scrubs. I walked to every room and I said, let me explain to you why you have brain fog in very physiological, biological terms, right? That's, I think, a point I want to make here is that there is an absolute biology to the symptoms that you're experiencing. There is a foundational biological foundational element to the reason you feel depressed, and it's estrogen. To your question specifically, estrogen is the hormone that is dropping in we have nice high levels premenopausally, and then of course as our ovaries and our eggs, as we run out of that egg count, we lose our estrogen sources. The estrogen is what feeds the brain. It works directly as a neurotransmitter in the brain, and it works in the serotonergic region of the brain, which, if anyone knows how an SSRI works for depression, right, it's building, it boosts that serotonin levels in our brain. This is how exercise works because it triggers serotonin levels, right? It can make you feel better. So, there is an absolute biology to the depressive symptoms that you are experiencing. So I want people to know that. And then I thought so much about our conversation, Rachel, and I have so much to talk about, but I think then there's so many other things beyond that end up being a reactive depression. I will say personally, when I started losing my eggs and my fertility, that was a real loss for me. I don't know. It made me, I had to face that. I had to look at that. I realized I was mourning the loss of my fertility.
Right.
And not everybody's going to feel that way, right? So
I appreciate your saying that, and I just want to make sure I heard you. You call it reactive depression,
yes.
or there are, I think, many sort of issues under that umbrella, if you will, and one of them is absolutely for many women the sort of facing the loss of their fertility. Yeah,
the weight gain, the lack of sleep, the lack of control. Your body all of a sudden is doing things that you aren't expecting. One day it can be very different from the next, right? And you've got to get a lot of things done. You've got to work, you've got to take care of kids, and if you don't know how you're going to feel the next day, that can really, from a mental health standpoint, be really upsetting. So you asked, what do you do? How do you streamline this process? I mean, education, and you are doing this, and Alloy's doing this, and several wonderful platforms are providing education for women. I think women have to educate themselves as best they can, take some notes, and go in with a sort of a concise plan and questions, and book a separate appointment. Don't do conjunction with your pap smear.
So true.
Yeah,
Such a great reminder. You may not get it in. And actually I've heard also, if you can, if it's helpful, book a double appointment so you have that extended time. That's really
right.
great.
If a practice or if that's even allowable,
Right.
right? Like I said, like our insurance driven
Yes.
model, and yeah, it's very it's a big challenge. We have so many barriers on so many levels, right? That's certainly a huge one. Educating our doctors, and anyway, we can talk about that. But so estrogen, try to educate yourself, come up with a plan. Estrogen is that hormone that we're losing precipitously in our perimenopausal years. There's that loop phase where actually, ironically, I'll go back to the definitions. You actually can have too much hormone in your system. And then 12 hours later, because the estrogen half-life is only 12 hours, you can be back down in the basement, right? So in one day, you literally are swinging high and then
One
low.
day is hell.
It's
It's
unbelievable.
so hard. It's so
Your
hard.
brain is trying to catch up. Your brain relies on estrogen for its primary energy source, which is glucose. And when you don't have your estrogen levels, your brain's not being fed its basic glucose energy source. So your brain is literally looking for that, and it takes time for that to adjust, right? So a day to day, a 24-hour period is not going to do it, right? This takes years for your brain to accommodate. And that's where, estrogen hormone therapy can be really beneficial and temper the symptoms, mitigate the symptoms. It's not a panacea. It's not everything, right? And it's really important. Let me also say this about depression. Uh, it's really important. If this is truly major depression, a psychiatrist needs to be involved,
Yeah.
right? We need to treat major depression. I'm by no means saying that estrogen is a substitute for treatment of major depression, but really interesting. This just came out of England like a couple days ago, from Louise Newsom. She let us shared it with a bunch of us that they did a study about in England in different communities and they were following SSRI use and hormone therapy use, and in the communities where where the hormone treatment levels were higher, where they were treating more women with hormone therapy, they had lower
Yeah.
RI rates. So for these sort of perimenopausal symptoms of depression or depressive symptoms or intermittent, estrogen certainly plays a role to mitigate those symptoms.
Thank you for that, Dr. Flagg. You're giving us an amazing amount of information. I'm super grateful. I just to that particular point, and again, sort of like piggybacking it off of the changes in the language and the ether around MHT and just sort of understanding hormones in general and how much they impact. I've been speaking with clinicians and doctors and scientists for several years now, and it still took me a while to sort of appreciate that hormones are our first line of defense for many, and that I think that piece that Louise Newsom shared sort of speaks to that
Yeah,
and setting aside for a minute sort of major depression, which we can talk about more if you like, but certainly these feelings of low self-esteem, intrusive thoughts in some cases, lack of motivation, feeling flat, feeling blue, feeling irritable, but more or less able to
yeah,
maintain. There is a space that hormones can
yeah,
fill that can just help bring things, I hate to use the word balance, but
yeah, me too.
more into balance, more into focus
Yeah,
maybe, so that then there's room to kind of get through to the other silos where more support may be needed, or more attention to things like I don't know, nutrition, exercise, all the things that you don't necessarily even feel like you have the mind space to do,
even
which
race.
right. Yeah, yeah, yeah.
Yep, I find that
Um,
experience is I often have to put that hormone hand down and lift them up off the floor with my hormone therapy. We start, there's the six lifestyle measures, right? Sleep, nutrition, exercise, stress management, friendships, all of that. But I feel many times I have to hand off the hormone therapy. We have to fix that first.
Mm.
And that brings them back to then they're able to embrace some of these other things. There's no way a woman in their 40s with all those other things that we talked about that they have to manage can attack 6 lifestyle pillars at once. That's impossible, right? So I really, in my discussions, if they're open to hormone therapy, and that's something on the table, we start with that, and then maybe we address one other thing. Let's take sleep, right? That's so important. And when when we have insomnia and we can't sleep, that exacerbates
Yeah.
all of this stuff. Right?
Yes.
I focus a lot. I'll hone right in on that. We'll tailor their hormone therapy, make sure they're on micronized progesterone because that really helps sleep. That works in the GABA region. And then we talk about sleep hygiene, right? Getting off your phones, not drinking caffeine after noon, emptying your bladder, little fluid restriction after dinner time, setting a bedtime, magnesium glycinate at bedtime, all of the nice, bath before bed, if one can fit that in. All these sort of sleep hygiene things. We focus on that. If we get the hormone therapy in line and we get some sleep hygiene in place and improve some sleep, it's amazing the downstream effects. Then you can, get a little more exercise or go see a friend because you finally feel a little bit bright, right? So you really have to break this stuff down.
Yeah.
You can't on it once.
I for anyone who may have had episodes of depression or moody blues, and again, I want to be really careful about major depressive episodes and sort of package that a little bit separately.
Yep.
But if you are someone who perhaps, if you've given birth and you had postpartum, if you've had episodes of anxiety or depression in your younger years, should you expect or not necessarily that this may crop up again?
Actually, a fantastic question, and it's one I think about all the time because I think that our individual bodies as a woman is such a unique situation for every single person, and we are put to the test many times in our hormonal journey, right? So as a teenager, in your 20s, when you are pregnant, in your postpartum, right, you're put to the test with high levels of estrogen, low levels of estrogen. For example, when you're breastfeeding, your estrogen levels are super low. They're 0.
Right.
Prolactin levels are elevated. Your estrogen levels are low. So it's almost, I spoke years ago on a panel about this, actually. I asked everybody in the room, I said, all right, who, when you were breastfeeding, had vaginal dryness and what we call genitourinary syndrome of menopause, right? The vaginal dryness when you were breastfeeding. I treat people with topical estrogen. I always have.
Right.
Time, to offset that. But they can have terrible vaginal dryness. And I would love to do the study that shows that may be a little glimmer, not glimmer, it's not a glimmer. I take that back.
No, I know what you mean. A
Red flag.
highlight,
It's
an
more like a red
amplification.
flag.
Yeah.
Take that back.
I know exactly what you
A
mean.
glimpse into your future,
Right.
right? If it happens when you're nursing, when your estrogen levels are low, it's likely because that's the nature of your receptors down in the in the genitourinary area, down in the vulva and the clitoris and the vagina and all that, that you will likely experience that again in menopause. Not that
So
you think that far in advance, but
interesting.
it may be a
No,
sign.
but it's so helpful.
Yep.
And I think, sort of intergenerationally, that's why having these conversations is so
Yep.
important because our daughters and their daughters and so on can have an awareness, even if it's just like a little seed in the back of their head. It's kind of alarming to hear this. It's alarming to, not alarming. It's a red flag, right? And it's something that, as we're learning it maybe on the back end of something, it's like, wow, yes, that makes sense, I remember that, but
Right.
ahead of it, it's also incredibly helpful.
It can be prevention, right? You can use it as
Yes.
you can get on top of it before it happens to you. You
Yeah.
can start using estrogen at 45 and never have symptoms of vaginal dryness, right? We can use it as a preventative tool in many respects.
Absolutely, and should. Dr. Flagg, we've kind of like blown it out. And yeah, and but that's okay. I think we're excited and it's important, and it all, there's a lot to share in a not a very long amount of time. But I am thinking about, so I think I started perimenopause around 42. And the only reason I think that is because I had symptoms that were loud enough to me. They happened to be anxiety, and I was having some like depressive episodes, but I had had those as a younger person. So I just thought, life is stressful. When I think about that now, I think I probably started perimenopause, sort of the realness of it, right? The fluctuating hormones before I was 42. So it just something got louder, right? It was quietly insidious, and then it got loud, and I had to pay attention. So for someone who is younger and going to come across this conversation or is watching now, maybe in their late 30s, and we know how the conversation has changed around perimenopause and menopause just in the last few years. So for the most part, someone walking into a doctor's office in their late 30s and saying, I'm feeling particularly anxious, and I've heard this can be perimenopause, and they're not going to get tested. Like, what else should we be sort of on the lookout for, paying attention to? What are some of the other symptoms, and how can we decide, I think this is perimenopause?
Right. Um, you know, common things being common, right? It's something we say in medicine, common things being common, or the horse versus the zebra, right? The horse is more common, the zebra is more uncommon. Common things being common, perimenopause is going to happen to 100% of women with ovaries and a uterus. It's just, it's going to be, it's almost like you have to, the other things are much less common, but of course there are things like anemia, low vitamin D deficiency, some vitamin deficiencies, a thyroid issue that can contribute to overriding and overlapping symptoms, right? But it is incredibly common. Here's what I just wanted to point out about, in their late 30s. That's why the context and their goals, that's why that piece is so critical. You often have somebody, and where my language is really important when I'm discussing with somebody, not to make sure that it's sensitive, that it's because that person, it's really important for me to understand what are your goals for, do you want kids? Like, let's say you have a kid, and I really need to understand what's her goal, right? And then do you sit there and talk about perimenopause, or do we talk about, well, let's talk about how we can preserve your fertility and that goal? Those two conversations are actually on a collision course with each other, right? And I have to be really careful not to dive into the perimenopause. And that may have been the problem with that 42-year-old.
Right.
She didn't have a kid yet, and it was still in her head that she wanted to maybe have a baby. Right? And so of course she's going to react to me when I said perimenopause. That is not what she wanted to discuss.
Right.
It's really important to understand somebody's context. So it's important, I think, that's an important message, I think, to be really clear when you're speaking with your doctor, what your goals are. I'm having a lot of PMS. Maybe this is perimenopause. There's a lot of PMS and perimenopause, right? They're overlap, right? So we can, right? It's just mild and then gets a heck of a lot worse in your 40s.
Right.
So, there are overlapping treatments there too. You can focus in on the days that you don't feel well, with, spot checking, basically using a Prozac or whatever. I focus a lot on lifestyle and nutrition for those patients, or, we use the pill. To talk about hormone therapy in late 30s, I'm certainly open to that if that's where the discussion leads. It's also really important to rule out, this is really important also, to rule out, it's uncommon, but premature ovarian insufficiency. If somebody starts complaining about those symptoms that are really clearly sound very like they're perimenopause, it's really important that you rule out your ovaries, that you go through menopause earlier than typical, which is 51 and a half, right? So before 45, it's early menopause. And that's really important because the long-term health implications of that are tremendous.
Thank you for that, Dr. Flagg. I know we're going to be leaving soon. I'm going to hang on to you as long as I can, but just to sort of blow this out a little bit more, someone did just ask, as an anxiety sufferer and I think this speaks to exactly what you're talking about, but I just want to give you another shot. Um, should you want to add, how can you tell if the anxiety is the typical anxiety that one has always suffered from, or if it's related to perimenopause? I think you kind of answered that, but just in case.
Yeah, look, if you've had anxiety your whole life, and it's likely that it'll exacerbate during perimenopause, but it's not direct. It's not Perimenopause isn't the direct cause, right? So it's going to be really important that you're under care of a psychiatrist, and in a really ideal world, that your OBGYN or your menopause specialist, or not menopause, but primary care, that we're all working together to make sure we get the right treatment for that. And just, a trial of hormone therapy is really helpful. Like, that's a good way to rule it out, actually. If you trial hormone therapy, because there's no
Yeah,
blood test, right?
of course.
Test. You rule out other causes, common causes, but there's no blood test that's going to tell you in perimenopause, because those hormone fluctuations are so great, that's going to diagnose you, right? So it really is a discussion, and it's a very individualized discussion. Um, and sometimes it's, you trial stuff and you try it,
Yeah.
and I've done that with patients. 3 months,
That
go try it.
that's so helpful. Thank you for bringing that up. It seems like a minor thing, but it's
Right.
not. And whatever it is, whether it's hormones or and an SSRI or and dosing, or even the way that you're receiving hormones, patch, spray versus pill, all of those need your commitment to sort of trying it out and seeing if it's really kind of finding that sweet spot for you. Someone asked a question much earlier, and I just want to raise that with you about having her ovaries removed and the implications of that. And I guess it's kind of like my question maybe is like each side of the same coin. So sort of how would you um, help someone sort of understand what might be coming should that surgery be in the future for them? And then on the flip side of it, now you're in menopause, what are you needing to sort of pay attention to, psychologically, emotionally, mentally, and so forth?
My hope with anybody who's having their ovaries removed, of course, some of this can uh, uh, be linked to the reason they're getting their ovaries removed. So that has to be factored into the discussion. But it is really, really important that whatever doctor, surgeon you're working with is going to literally almost immediately put an estrogen patch, and potentially even testosterone. If it's just ovaries, if you still have a uterus, you still need progesterone in that scenario as well. But when you remove ovaries, particularly at a younger age, but at any point really, the long-term health implications are tremendous from a cardiovascular standpoint, bone health, cognitive function. We have clearly documented evidence that if you lose your ovaries, particularly at a younger age, that there's strong long-term negative health consequences from that. So what can you expect if your ovaries come out, say at 45? You, within one day, you will feel awful. That
Yeah,
immediate removal of your estrogen, that natural menopause, I mean, I,
I know.
it's not great either,
Yeah.
uh, because it's all that up and down, but it is a more natural progressive course. Removing your ovaries acutely like that, and you will get acute symptoms. And I've seen unbelievably, psychosis almost from people having their ovaries removed and it not being immediately treated with estrogen replacement. And depending on your age, it should be full estrogen replacement as opposed to hormone therapy, which of course is a lot less than
Right.
just enough to mitigate symptoms and optimize benefits. Hormone replacement therapy is necessary in these patients to avoid the long-term health implications.
Awesome. Thank you so much. A couple things, 5 more
Okay.
minutes. Do you have 5 minutes?
Yes.
Okay.
Okay.
So I just remembered, as I sort of stepped into this, social media
Yeah.
window, niche, whatever you want to call it, several years back, one of the things that triggered me to do so was this article. I've talked about this a few times. in New York Magazine, and it was called Midlife Psychosis. You might, I don't know if you got New York Magazine. This was like 2020, I think. And it scared the crap out of me because it was really all about, more or less, sort of the hormonal impact on women psychologically, um, in perimenopause, and women's lives were upended. I think it featured two or three women, actual living people. One woman, like, I don't remember, I have to refresh myself, but I feel like she ended up either in an institution or in prison. Like, she really was psychologically
Yeah,
derailed. And so I guess I say that because it really is a thing.
yeah,
And if you are struggling in various ways and you are, certainly in your early 40s and throughout your 40s, and also, I think this is important. Your periods may not be changing yet. Like, there are things we sort of know to look out for, hot flashes and night sweats and period changes that you may not experience. And you continue to sort of remind us how nuanced and tailored menopausal care needs to be for this very reason. But if you are struggling psychologically, don't kind of wait on it and think that it's really not a big
right.
deal. Would you agree?
I agree.
Yeah, I agree.
I
Great.
totally agree. And the lead symptom of perimenopause, I always, for many years, thought it was period changes. They get a little closer together and a little heavier as those ovaries decide not to respond to the brain, or they do. But it's actually fatigue. And try to every woman is fatigued, right? And of course, for them, they're like, of course I'm tired. I'm taking care of 3 kids. I have a full-time job. I have a partner, right? We explain these things away,
All the
but
time.
fatigue is a lead symptom. Apparently, we've kind of learned that recently.
Yes, we've learned it and we've adapted. We're so adaptable, and our sort of culture sort of reinforces that and expects it. And so we do it, but to our detriment often.
Correct.
All of that being said, I also want to give you time to talk about all of the good, because there is so much. And I know we sort of like, it's like jumping from one extreme to the other, but you brought this up also in our conversation. And I think it matters to you to share, and it matters for us to hear it. So when you brought it up, and maybe you don't
Yeah.
remember, but
Why don't you
thinking
remind
of it
me?
right now, yeah. Well, maybe if you remember what you had in mind, or if just thinking about it now, what is it you want us to sort of walk away from knowing about this piece?
Um, I really wish I could remember exactly what we talked
It's
about.
okay,
I
and
don't.
don't feel put on the spot.
No, no.
I
Obviously, there's silver linings, right? But there's no question it's a process, and I would say what I'm really thrilled about in the last year or two, and it's quite frankly, I mean, it's made the conversation for me day to day with my patients. It's open, right? There's a lot more exchange of information now, in many respects easier. There's a lot more to talk about too, but um, I I absolutely love that the narrative is changing, and that we have opened this up, and that we can say menopause out
Yeah,
loud without having terrible connotation and implication. So the last year or two has been wonderful that way. And and then, I mean, it's a Titanic that we have to swing around, right? And that's not easy, because what it has uncovered is multi layers of challenge, right? On an education
right.
standpoint, from patient to doctor, all the way through the system, to insurance catching up, providing codes, therapies. I mean, we can go on and on, right? But silver linings. I mean, you will get through it.
Yeah.
You will get it. And if you educate yourself and arm yourself with information and a plan, and find hopefully a supportive doctor, to help you, a menopause specialist, nurse practitioner, menopause literate person to support you through this process, all the better. and places like Alloy and Rachel providing lots of great driven information is really helpful for everyone. So we just have to keep talking to each other and get through it together, basically.
Um, Dr. Heidi Flagg, I said this in like a video I did the other day, but I've had my eye on you and I've wanted to talk to you for so long now. We've sort of been like staring at each other from literally across a room
Yeah.
for years, when we've been under the same roof. And um, I knew when we sort of, when we exchanged numbers at some event, I thought, oh yeah, she's the real deal. And then we've gotten to speak a few times since, and I'm so grateful for your time today and for your sort of will and want to help all of us going through all of this. It's a lot. And to address the mental health part is a lot. It can feel daunting and in many ways worse than some of the physical stuff, right? Um, so I thank you for your knowledge and expertise and time today. It's just lovely, and you're lovely. And for those of you, a few people had asked, what's this doctor's name? It's Dr. Heidi Flagg, Flagg, and she is not Heidi Flagg on Instagram. She is M_pause. Yes, do I have that right? Yeah. Okay. So look for her there, and we will both be sharing all of this anyway. So
Rachel, thank you for
thank you, Dr. Flagg.
having me. Thank you for everything you do. I
Thank
really appreciate it.
you so much. I appreciate that. Bye,
Take care.
everybody. Be well. Thank you so much. Bye.